Hello everybody and welcome to this WHO Social Media Live. My name is Nyka Alexander. I'm joined with three colleagues. I'm joined by three colleagues from WHO. I'll introduce them in a second. Our topic today is facing the health aid crisis, but don't log off, stay tuned in, and I think you'll see that we can make this topic quite interesting and that it actually matters to everybody. So I'll start off by introducing Alia to my left. Alia El-Yassir is the Director for Gender, Equity, Diversity, and Rights for Health at the World Health Organization. Next to her, we have Abdou Salam Gueye. He's our Regional Emergency Director for Africa, for the region of Africa. We have emergency directors for each region that WHO works in. Welcome, Salam. And then we have Meg Doherty. Meg is the Director of the Department of Global HIV, Hepatitis, and Sexually Transmitted Infections. Welcome, Meg. So today we're chatting about the topic of the health aid crisis. What does it mean when we say that? You may have heard some headlines recently. My colleague Anka brought up some headlines so we can put you in context. So headlines from the Associated Press, for example, that cuts could cost lives. South Africa says its budget can't cover for the deep cuts in foreign aid. Children die as aid cuts snap a lifeline for the world's most malnourished. In HIV and tuberculosis, Health Policy Watch said cuts to South Africa will cause global loss of TB and HIV research capacity. So what does that mean and why do we want to talk about that? Maybe I'll start with you, Meg. What's going on, basically? Why are people talking about money suddenly having disappeared from projects around the world? What does it mean?
Well, to be honest, we should put it in the broader context that for many years we have had a sort of a golden age of funding for HIV, TB, malaria under the Sustainable Development Goal plans. And especially for HIV, there is the PEPFAR program, the President's Emergency Fund, for scaling up HIV treatment and care that's been now going for 20 years, saved 25 million lives. And so, but for many years we've been talking about we need to be moving towards a more sustainable plan where there would be integration of HIV into primary health care or TB and malaria. But what happened over the last 3 months is not just U.S. government money cuts, it's cuts across all ODA or funds that go into development. And that means that many programs that had not yet started to shift over to a more sustainable primary health care approach were left without enough funds to keep people employed, to keep the clinics open, and to move antiretroviral medicines, life-saving medicines around the world, around their countries. So that's why we're hearing about these news titles, these news medias, because there is concern that there are people who may not have received their antiretrovirals. There are people who may not be able to continue their important clinical trials and research. And that means that we're potentially going to have slippage in our ability to cover people with life-saving treatment.
Can I summarize it another way, and please correct me if I'm wrong. So in some countries, they don't have enough money in their own budgets to cover everything that needs to be done for the population. And since we're the World Health Organization, we'd be talking about funding for health programs. And the US government and other governments traditionally have given money to countries to help them out in some areas, and that money is not as available now from the US, as you mentioned, but from other countries as well. There are domestic issues that countries need to focus on. Their economies may not be doing so well. Many countries are increasing their funding for defense, so for their preparedness in case they need to fight a war or help another country fight a war. So basically there's less money for the kind of work we do. Is that another way of putting it? And so you work in HIV, AIDS, tuberculosis, and so on, so that's a particular concern whether people who have those diseases can get the medication, the testing, and the support they need. And then Salam, you work in emergencies, so where are you concerned? Where have you seen the impact of this money not being as available as it used to be?
Thank you very much. I think I will start like Meg said. It has to be put in a global context. We just came from the COVID-19 pandemic, where after initial reluctance to cooperation and also to support others, there were a lot of donors, whether in the public sector or in the private sector, that were very generous for emergency program prevention, preparedness, response, and resilience. And we start having a little habit of that. Start having a higher ambition, higher target, and working with countries and want to solve a lot of issues at the same time. At the end of the period where COVID was helping us get money, it was decreasing and we were adjusting. And there is a sudden cut of funding from the U.S. government, but it is not only the U.S. government. Other government also has shown little reluctance to provide funding. So we have now some issues, first that are internal. For example, the flexible fund we have, which is the only fund eligible to fund salaries for long-term staff, become a little bit less. And we have some difficulties paying all the stuff. And also some program activities that used to be done and renewed sometime on a yearly basis or 2 years or 3 years. We have now some information that it may not be renewed. So even if the money is available today, we don't know for the next biennium how it will be. And finally, we have what we call the appeal. Each time that there is an emergency that show up, there is a Ebola in Uganda, a Marburg in Rwanda, or a cholera in South Sudan, we make an appeal to the international community. Say, here is a problem, here is an opportunity to invest on humanity. And people was responding very favorably, and we were able to respond to it. And now, when we do that, usually it is coming with 30%. It depends to the topic. For example, if it is hemorrhagic fever, often it is higher, around 80%. But it is some topic like cholera, it is sometimes even zero. We have launched some appeal recently where we did not have a single dollar.
Although that has happened other years as well. I know cholera is a hard disease to raise money on for some reason. It can be a challenge.
Absolutely, Nyka.
Yes.
This is not new. We are on the system. It is a cycle where we do not have money on the global health in general. Before 2003, it was a lot. I was clinician at that time, and literally we were watching HIV patients dying on the wards. And it is PEPFAR that came with a generous initiative from George Bush II, the president, with PEPFAR, and that's where a lot was solved, and it extended to malaria with PMI, the Global Fund. And at that point, we had a lot on those area of intervention. And it went down, and after we adapted, and each crisis is an opportunity for innovation.
We're going to get to that because we don't want to be the Debbie Downers that only have bad news. My colleagues who are monitoring our social media feeds tell me that you're dropping in what countries you're visiting us from, which is terrific, and I'll be reading a summary of those in a little bit. But right now I wanted to remind you that this is Social Media Live because we want your questions. We want to know what you want to know. We know what we think you want to know, but we'd like to know what you would like to hear us talk about. So this is how you do it. If you're on X, you write hashtag AskWHO and give us your question. If you're on LinkedIn, YouTube, or Facebook, just drop a question in the comments, and we have a whole team of people who are following your questions and will let us know through my phone what you'd like to hear about. So please let us know. All right, so I said that we didn't want to be depressing the whole time, so you just said, Salam, that there's an opportunity in every crisis, and I will pivot to you, Alia. Can you tell us what you see as the opportunity at this time? When there's less money coming from international donors, where else can money be found?
Well, I'm not sure I can answer, there's no magic solution to where money can be found. And if I can just touch on a conversation we were having actually before we went live about how important global cooperation really is. I mean, we exist as an organization. We're part of the larger UN system because there is this intent to continue global cooperation. So just to underscore that is really critical and needs to continue. And that's very relevant to the areas of work that I am advancing when we come and talk about health equity, advancing gender equality, addressing discrimination and human rights violations, because there is a global understanding that however good countries are in their health systems, in their education system, across the development sphere, there are people that tend to get left behind because there are blind spots. And so what I would want to say is, even if we shift the focus from where the money is coming from, we do have to look at how we're investing whatever resources are available to us. National budgets are key and have always been key in terms of supporting health systems, but how do we assign the spending in a national budget so that it is driving health outcomes equitably? And that's where we need to look at the way that we are designing those budgets. So of course there's opportunities. There may be a sense of we need to contract and centralize, but actually that would probably be the wrong way to look at it. You need to look at the community level, because actually your communities are the ones who are going to be stepping in and supporting you in time of crisis. We know this from previous crises. So there's an opportunity to act differently. There's an opportunity to look at what data is going to tell us about who is being left behind, who is feeling discriminated against and excluded. We know that from our colleagues across the globe that at least in 25% of the countries, out-of-pocket spending is increasing.
So out of pocket is where you have, if you have a health condition or you have to go to the hospital for something, you have to pay more for it yourself. There's not a health insurance that helps you pay for it. Okay.
Exactly. And that's where the community level is really important, that it comes in, because they can help to identify who is most vulnerable, exactly, and where health systems need to kick in. Because choices about who gets access to healthcare or which type of healthcare are going to be decided based on how much money members in a household have. So I think that's a really important angle, and so you need to have community ownership and leadership when you're doing your looking at your financing, as well as national leadership and ownership. You can see there was a big event yesterday which was looking at data and financing, and you see incredible examples where countries are sharing. You have some countries, I think Barbados has a health levy. You have in Liberia, they've set up a health equity fund to support those.
In response to the cuts?
Not in response to the cuts, but understanding. And so these are mechanisms that can be put in place and scaled up to weather a crisis. So I'll stop there, but I can say more.
We have a couple of questions, and I will put this one to you, Meg. This is Jasmine Zahn, who's asking, could you share your vision on how the current crisis will provide a chance for a TB diagnosis in a global context? So I guess she means, how do we increase access to diagnosis so people can test whether or not they have tuberculosis?
No, I think I would take the same term, in a crisis there's opportunities. So part of the work that we're doing in infectious diseases, those that have been supported by PEPFAR, Global Fund, is looking at what can be prioritized, reprioritized, what are life-saving interventions. And certainly, as Jasmine is bringing up, testing is the entryway to any kind of knowledge about a disease. And so we don't want to have testing and diagnostics to actually slow down. So there are many innovations that are coming out around self-testing. In HIV, we already have a very well-established program of self-testing, taking it home, doing that as well for syphilis testing, for hepatitis C testing. So I think more and more we are going to be looking at what are the innovations around tuberculosis testing, which is often done in a lab, to bring that closer to home, closer to communities. And absolutely.
More privacy.
Privacy, you reduce stigma, you can decide when and where and how to test, who you want around. And I think in some ways, most people, for example, for HIV, might test 1, 2, 3 times before they decide to get treatment and care. So for tuberculosis, I think there's some innovations on the horizon that will make testing cheaper and closer to home, and I think those are some of the innovations we need to bring. And also, HIV has some learnings where we put testing kits and treatment in pharmacies, so actually taking it a bit outside of the health sector so that there are greater availability, increasing equity, as Alia is speaking about, because right now it will be the people who are potentially most marginalized, those who are stigmatized, who may be left behind as we move forward.
one step easier if you can get the testing kit at your local pharmacy rather than having to make an appointment with your healthcare worker and so on. We have a comment, so I hope that answered your question, Jasmine. These are all on LinkedIn so far. There's a comment from Wahid Farjad who says he hopes funding is raised more in the future on health issues which are critical for the lives of many people, especially for children. So we'll talk a little bit about that, Salam. I just want to remind everyone that you can ask your question on LinkedIn, on YouTube, and on Facebook just by dropping your question in the comments. And if you're following us on X, use hashtag AskWHO, and then we'll pop up and we'll be able to ask your question. So we always say that women and children are the most affected when there are emergencies. We also always say, as you did, that the communities are the first people responding. They're already there when an emergency strikes, and they're the last people responding because they live there. So they're not going to go away. They don't pack their bags when things are finished. But tell me in your own experience, and I'll just want to summarize here what an emergency means when at WHO what we mean. So a disaster, a flood, or an earthquake like there was recently in Myanmar, outbreaks such as Ebola and cholera, which Salam mentioned already, or a war has a huge impact on health. Sudan, Ukraine, Gaza, those are some of the ones that WHO is following and working on. We have colleagues in all of those countries. But when you've responded through all these years to an emergency, where do you see the impact on women and children? Why do we always say women and children are more vulnerable in emergencies?
Thank you very much. The notion of vulnerability, when you try to understand it in the field, is a group of individuals that are closer to the disaster, to get arrived, for example, to die or to have some pain because of the emergency. The emergency being a disaster, being an outbreak or something else. Women and children, often in many societies, they do not have a lot of resources or sometimes enough protection to protect themselves, or there is an unwillingness also from the authority to provide them the extra mile protection they need. So when there is an emergency, often they are the first victim. In this context where we do not have all the resources we need, usually we tend to prioritize, saying that how much should I invest and how many lives I should save. If people are often not protected at all at the beginning, you have to invest more to save them. And if you are going into only a rational calculation, you may say, I better save this person doing a little effort than doing the extra effort to save the child or the woman. That's where ethics come and equity. And we work in real collaboration with our colleagues that make sure that we are offering a chance to everyone. Another issue that is really important also, it is minorities. Beyond women and children, every group you see, there is some minority that may even not be aware of what's happening. They are the last to know. And also when it happens, usually they may be the source. In outbreak, often people would say that it came from the minority. Even misinformation. Yeah. And all those, WHO tries to really bring back the reality with data, with evidence, and also trying to make sure that people are not held to something that they are not responsible of.
I have another question here. This is from Annetta Wilson Barnett on LinkedIn. She's basically asking us for a response. She says she agrees, or she agrees, I'm not sure that we said that, but she says that WHO took for granted that funding would always be available, and the WHO could invest more in local medicine and personnel development at the regional level, and I assume you would agree as well, Annetta, at the country and community level, which has been mentioned now as well. I believe they have the knowledge and expertise to work to invest in developing solutions, including pharmaceuticals, personnel development to solve local problems, and decrease dependence on aid from different countries. I just want to add a comment. I was at an event this morning about community protection with WHO, UNICEF, and the Red Cross, and one of the health workers there spoke exactly about that. She was a community health worker, and her ask was to invest more in her, help her have more information, have more medical kits, because the communities trust her. She's from the community. When she tells them this is what Mpox is, if you remember, Mpox used to be called monkeypox. When she says this is Mpox, these are the symptoms, this is what to do if you have it, they really listen to her much more than they would somebody else coming in from outside. So what are your thoughts, and I'll throw this open to any of you, what are your thoughts on how important it is for the money to really be used where the rubber hits the road, as they say, where the first responders are, where the communities are?
I think that it already is. I mean, I think there is maybe conflation between what money is going to WHO versus what money is going towards health.
Yes.
And it is, what is coming to WHO is a drop in the ocean compared to the larger health investments. So I think,
As it should be.
of course, and it's always been like that, and it should always be like that. I don't think that there is any understanding that it isn't that way. I think she touched also on a point in terms of indigenous knowledge, traditional knowledge, and that's the kind of issue that is actually being discussed here in the Assembly. Sometimes these kinds of convenings may seem to so far removed from realities on the ground, but it is actually in this space where member states can come together and agree to put value on this type of knowledge as a collective, and that then drives countries to implement these agreements, so that there is this is what we mean by kind of a standard that is agreed between countries that can then get implemented within a particular country. So in fact, in this assembly, there is a strategy on traditional medicine. And so I think that is definitely part of the thinking of WHO.
Thanks for putting that in perspective.
Yeah.
I just want to add something. Oh, actually, we have a question. We have a lot of questions. We almost have more questions than we can answer. Our Director General, Dr. Tedros, he often makes the point that WHO's budget is the size of a hospital in a mid-sized city. So sometimes when you hear the millions of dollars that go to WHO, you think, well, that's a huge amount of money, but it isn't, considering how much work is done and how many people you need to do that work. And we're not keeping it all to ourselves. Our money goes towards the people who do the work in the field. So this question is from Hervé Iradukunda Ntwali, and he's asking, what emergency funding mechanisms exist for countries facing acute health system collapse, and how can we access them? So how do you help countries where their health system is in collapse? I've seen, for example, right now we know that in Gaza, it's very hard for the health system to keep going under the attacks. It's very difficult for WHO to bring in supplies. There are supplies waiting at the border, but we haven't been allowed to bring in very many supplies recently. So that's one place where the health system is facing collapse. But maybe to talk more about a place where the funding shock has brought a health system closer to collapse.
I think I may start that question, and you may add what you. The health system may be collapsed on several ways. There is some sudden collapse where it is a big crisis. It is a disaster, it is a war, and suddenly overnight the system is not working. It may also be something progressive or longer term, where there is a protracted crisis that has been in the country for a while, and that country is not able anymore to make the health system work. And sometimes also both of them may be combined. Just to give an example, on North and Southern Kivu, recently there is a war, and at a moment the government was not able anymore to be present and play the role of the government. And the health system that was maintained by government workers, where the supplies was coming from the government, start having problems. So WHO at that time was able to pitch in, and we were able to negotiate with the neighboring country to let us in. When we arrived, three things was our objective. The first is to find out where the supplies are. Ourselves, we have our medical storage, where we have over 30 tons of medicine. We took out those 30 tons of medicine, gave it to the public services, gave it to NGOs and other volunteers that were providing primary health care in the field. We also asked to all the partners if they have some stock of supplies. And we were able to identify around $11 million value of supply that was closed somewhere, but the partners that was in charge of distributing did not have access or did not have the immunity or at least the protection necessary to do it. And they gave the possibility for WHO to distribute it. There is another part where WHO also was working an important role, is the coordination. because there are so many partners working there. They want to know where they are needed the most. If they are providing surgery, where the people that need surgery are. They are providing maternal and child health, or they are pediatrician, where they are needed. And WHO can coordinate, tell them go there. Otherwise, they all may go in one side, and the rest will be left over. And in addition to the supply and the coordination, there is another aspect where also in time of crisis, very contradictory information coming from all parties. And WHO has the credibility to provide the right information. And so people can use it for decision making, whether internal decision making or outside decision making. So our first teams that arrived to Goma for over 6 weeks, WHO was kind of playing an important role on those three parts, but also we were also delivering some primary health care through our rapid response teams.
I've been in many deployments and responded to many emergencies, and I'm always really proud of WHO and to see the work we do. And it's not a cookie cutter approach. Depending on what the country needs, we adapt to what they want. Just as you're saying, if they need coordination more, if they want us to help with the emergency medical team offers that have come from foreign countries. Other times we even speak to emergency medical teams and say, can you help on this? We see there's a gap. We see this hospital's collapsed. They need a temporary hospital. Turkey, can you build a hospital, a field hospital, and so on. So that's the kind of, it really depends on what the need is. And that's where the expertise is. That's why you pay to have people sitting in these positions that can be sent out to multiple emergencies, and they know each time they can bring their experience from previous ones to the latest ones and help things move more quickly in support of the local people. And here's a comment from Gabriela Ramos. She says, as a community outreach officer for more than 1 decade, I completely agree. More funding for health promotion and prevention in the community. I wanted to add something as well. If you're curious on what is WHO doing to help countries respond in this time when there's less money for them, WHO has done a survey of countries asking them what kind of support they need and has made a 4-prong suggestion or 4 points for how they suggest countries respond. Number 1 is to prioritize the poorest people, spend money to protect health budgets, that donor money that does come in should go into the national budget and not to the priorities that the donors might have themselves. And 4th, to avoid cutting services or closing facilities. And Meg, you might have something to add there as well. Can you put that in, if you're thinking about HIV/AIDS? Actually, I want to push you a little bit. This is something we talked about before the camera started rolling. Some people think a country like South Africa, which was receiving a lot of funding, shouldn't have to receive external funding, should be able to fund everything themselves. So, and you explained that actually they do do a lot of the HIV and AIDS care themselves. So can you unravel that a little bit and help explain?
Yeah, no, it is true that South Africa has the largest burden of HIV around the world, with 8 million people living with HIV and about 6.2 or more on antiretroviral therapy. So that's a huge burden. But they've been funding the lion's share of their antiretrovirals already. They purchase them, they develop them as well in country. I think what has happened with the reduction in funding is that certain programs that were set up from community organizations or to supplement, to be able to have services that were for what we call key populations or vulnerable populations, populations who might be stigmatized against, those programs suffered quite a bit. And those were the ones that were shut down because they were actually being funded by an external source of money coming in from the United States. There also was extra support for the healthcare workforce for a period of time. Maybe 2,000 or so healthcare workers lost their job, but that's a small comparison to the large number of healthcare workers who are working in South Africa that the government supports themselves. So I think it's a balance, and we know that they're suffering right now, but that we also know that there's a commitment from the government, from the Ministry of Health, to put extra money towards this, to continue the testing programs, and they even have an agenda initiative right now to put 1 million more people on antiretroviral therapy this year. So I think it's incumbent upon us, it's part of our job to see how can we help South Africa or other countries achieve their targets and goals while noting that they're going to have to come up with different approaches to fund some of these special programs. And if they are seeing vulnerable populations in the public sector, how do we protect them, make sure they're not stigmatized, or help with ensuring that everyone has the opportunity for a healthy life? Yeah.
And I'll come to you next, Alia, because we're talking about equity, and I think we want to explain it a little bit. We use equity all the time, we know what it means, but I think that would be a nice one to explain. But I'm just going to say, again, we're getting a lot of questions, so thank you very much for that. We won't be able to get to all of them, but I suggest you read each other's questions as well, because you'll get a sense of what people are interested in. But the way to send us questions is to use Ask WHO on X, and then simply put your question in the comments on LinkedIn, YouTube, and Facebook. But we're going to have to wrap without asking all of your questions. And so I'm going to ask you to explain what equity means, but with this in mind. So this is a question from Ronald Robinson, who says, why is it so difficult to get funding when the healthiness of people should be top priority? And actually, when you do surveys, when you ask people during election times and so on, what's your top priority, they'll say health. Or when people talk to each other, they say, I hope you're well. Yet governments don't seem to prioritize it the same way. Sometimes, the Minister of Health is not necessarily the most powerful person in cabinet. And that's always been a mystery for me as well. As a human level, we all know how important health is, yet somehow it's not the priority. So that was a good question, Ronald. So what are your thoughts on that? It's a big one, right? No big deal.
I mean, no, it is a big one. I think in my previous life, we were working with governments on budgeting, and I think there's always these really difficult trade-offs when you're designing a national budget in terms of what the priorities in the country are, and you see it even in the Sustainable Development Goals, where we say these are indivisible, they are all connected, because then you see, okay, education is also a priority, eradicating poverty is very important, and it's of course related. So I think there's always these tensions. But I think that's where we need also this kind of cooperation and advocacy, where, this is why at WHO we also talk about social participation, or this concept of social participation, where people are engaged, where they are speaking up and they are informing local and national plans and budgets, so that whatever, the investments mirror what it is that people are prioritizing. And, people will know that there are trade-offs, and it's really important to do that. But economic development is, still the defining kind of priority for many countries. But now defense spending, it's very difficult to make these decisions. But I think as people become more involved, then the decisions about the plans and budgets become better informed, And I just wanted to touch on equity, because it is actually this kind of process helps you to be more equitable.
Which means more fair, which means...
It's about fairness, but it's also about understanding that there are barriers. And not all people experience the same barriers in the same way. There are some which are tangible, which we can see, so your socioeconomic status, how much money you have to spend is something that is a bit more tangible. Sometimes legal frameworks, whether you live in a remote area in a small island state or on the top of a mountain, will affect your ability to access services. But there are also things that are less you don't see, but you also have to address. So social capital, like the power that an individual has within a community, norms, so societal norms that put men and boys at an advantage over women and girls. It's not so tangible, but it really becomes entrenched in systems, and so you have to address them if you're going to be more equitable and more fair and ensure that everyone has access to all the health that they need over their life course. So this is what we would be advocating for.
And just one thing we always would like to mention is that for WHO, health means physical and mental health as well. We're wrapping up, and I'm going to ask each of our panelists to think of just a couple of words of what gives you hope. So not full sentences, but just say a couple of words, and I'll come back to you in a second. So I'll give you a chance to think about that. Before we wrap and before we get the final words from our panel, I just want to run through the list of countries where you have joined us from today. So, England, Mexico, Egypt, the Democratic Republic of the Congo, Spain, Uganda, Ivory Coast, Tanzania, the US, India, Zambia, Iran, Saudi Arabia, Ethiopia, I'm halfway through, Afghanistan, Ghana, Indonesia, Pakistan, Colombia, Switzerland, where we are now, Bangladesh, Iran, Saudi Arabia, Brazil, Sudan, and Cambodia, and maybe even a couple more that we didn't capture. So thank you so much for joining. We do these regularly. At the moment, and Alia has mentioned this, we're not in WHO, we're at the UN's headquarters here in Geneva, Switzerland, where we have our annual assembly where the ministers of health and other policy makers get together and talk about what they want WHO's priorities to be for the year ahead, how much money they think we should spend, where they think we should spend it. So that's how WHO is organized. But during this time, we always make ourselves extra visible. You can follow all those sessions. Some of them are really interesting, quite gripping. The session where WHO member states, where the countries agreed that we should have an agreement, a pandemic agreement that will help us be better ready for the next pandemic. That was actually a really emotional session. That was Monday night. So just keep your eye on all of our platforms. Everything is highlighted on all those platforms, so you can be part of it. You can watch yourself. So, as I close, I'd like to come back to each of you and just tell me what gives you hope in this climate where there is less money, where we see more conflict, we see more disasters, climate change is driving more outbreaks and so on. What are a few things that give you hope? And not full sentences, just a few words.
What gives me hope is civil society is very active in holding us accountable, making stories available, and innovation will take us further. For HIV, we have a great innovation in lenacapavir PrEP. It's a long word, but it's a new prevention tool that will help us, we hope, get to the end of AIDS as a public health threat.
What gives me hope is that we are talking about humanity, and our greatest asset is human being. And it is not only money that motivates human beings to work. And we had that experience in emergency. Recently, a lot of people are volunteering to have a $0 contract with WHO in response to emergencies. It effectively happened on the Marlborough response in Rwanda and worked very well, whereas Ugandan people, Sierra Leone, Liberia, that volunteered, over 50 people, work and respond for $0 contract. So it means that this crisis will create, again, more commitment instead of reducing it.
No, I mean, people power. No, I mean, where there's a will, there is a way. And it's from the grassroots, from the community level, all the way up to the politicians who are here. You really hear it. There is a real commitment to do better, to do the best that is possible with what we have.
So civil society, innovation, humanity, human beings, volunteering, commitment, people power, having the will and having the way. Thank you very much for joining us today. Thank you to the panel. And as I said, stay tuned across all our platforms. Our Crack social media team is doing content about this week and also sharing things live so you can follow along. Thank you for joining us today. Thank you for all your questions, and see you next time.